Nothing. Hi, everyone. Thank you for joining today's call. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Today's presenter is Dr. Neil Vora, Director of Informatics, Data, and Outbreak Response here at the Health Department. Please note that you have all been placed in listen-only mode. If you have any questions during this presentation, please submit them via the chat box, and we will address them as time allows. Thank you, and without further ado, here is Dr. Vora.
Good afternoon. All right, there we go. So we'll start by saying a disclaimer that our understanding of the novel coronavirus and this pandemic is evolving rapidly. Literally every day, if not every hour, new information emerges. So this information is based on our best knowledge as of today at 1 p.m. And also, before I continue, I know that many of you on this phone, on this conference call today, are clinicians on the front line, and just want to express my gratitude for all of the work that you're doing. You are the front lines in this war against the coronavirus. Many of you are working under extremely difficult circumstances, and your efforts are very much appreciated. Thank you for your service to the city and to pretty much the entire world. Unfortunately, New York City is very much an epicenter of this outbreak at this time. So where we are right now, we're in the midst of a global pandemic of this coronavirus illness called COVID-19. We have widespread community transmission of this coronavirus in New York City. And over the next few months, a large proportion of New Yorkers will get sick with COVID-19. That means that things are going to get worse before they get better. And our healthcare system is going to be tested as it has never been tested before. But together, we can and we must work to slow the spread of this virus and protect those at highest risk for severe illness and our healthcare workers. By way of background, this outbreak started in Wuhan, Hubei province in China in December as a cluster of respiratory illness of unknown etiology. At the time, there were approximately 40 cases that were identified. There was basically reports in all of these individuals of some type of exposure to a live animal market, suggesting that there was animal to human transmission. And early on, the data out of China was suggestive that there was not a lot of person-to-person transmission, though clearly additional data has since then proved that to be not the case. The bit of good news in all of this is that scientists worked very quickly in China to rapidly identify this as a novel coronavirus. So by mid-January, they had identified the etiology of illness as this novel coronavirus, had fully sequenced it, and posted the sequence to an online open access repository. So the name of the new coronavirus is SARS-CoV-2, and the disease it causes is COVID-19. Around the world, right now, there are over 980,000 cases and over 50,000 deaths. So there are cases on every continent other than Antarctica. In the United States, there have been over 226,000 cases with over 5,000 deaths. And as you can see by the circles on this map of the United States, unfortunately, New York City is at the center of the epidemic in New York, in the United States. So diving into the data for New York City and New York State, in New York City, as of this morning, we have over 48,000 reported cases, over 1,300 deaths, and over 9,500 hospitalizations. You can get these data through our website. Look at if you go to the link below, nyc.gov/coronavirus, we have a new data dashboard that is interactive, and I encourage you to go see that website to get the latest information. Also in New York State, outside of New York City, there are over 36,000 cases as of yesterday. This is a graph based on our syndromic surveillance system. The x-axis shows the date going back all the way to October 1st of 2019, or actually, well, October 1st. The axis goes all the way to April 1st. The y-axis shows the daily number of visits, and you see different colors on the graph. The one year that stands out, or a date range that stands out, is 2017 through 18, and you'll see that that was a very bad seasonal influenza year. And during that seasonal influenza period, there was a major uptick, as you can see in the gray line or the dark blue line, of visits for influenza-like illness and for pneumonia visits to emergency departments. The orange line represents data from the most recent season. And we also had a surge in influenza-like illness and pneumonia visits to emergency departments during the early part of 2020. It decreased. But what you can see from March 1st onwards in that orange line is that the number of emergency department visits for influenza-like illness and pneumonia has increased. At the very tail end of this graph for 2019 through 20, you see that there's a slight dip, but be careful with interpreting that because, again, there can be fluctuations over small periods of time. This next graph, the x-axis shows the date, the y-axis shows the number of admissions, and these are hospital admissions for influenza-like illness and pneumonia syndrome. So what you see in this graph, again, is that from basically early March up through now, the number of hospital admissions for influenza-like illness and pneumonia syndrome has dramatically increased. Probably related to coronavirus, certainly related to coronavirus. This next slide describes deaths in New York City. So the easiest way to read this table actually is going from right to left and focusing on the bottom row first. And you see that, unfortunately, in New York City, for coronavirus, there have been nearly 1,400 deaths to date. When breaking this apart by the presence of underlying conditions, majority of these deaths have occurred in people who do have some type of underlying condition, such as diabetes, lung disease, cancer, some type of immunodeficiency, hypertension, heart disease, asthma, kidney disease, or GI liver disease. This table also shows other information broken down by age group, sex, and borough, and you can find more information on this on our website. This is a map of COVID cases by zip code around New York City. The deep purple color shows areas with a higher total count of COVID-19 cases based on patient address by zip code. And so you can see that there's a distribution throughout the city. Some boroughs seem to have zip codes with a higher number of cases. And again, these are data based on up through March 31st. I'm going to show you another map now, and this is the percent of positive patients. And so this is a different way of looking at similar data, but for this map, what you're seeing now is that there's a denominator of the people getting tested in a particular zip code, and the numerator is the number testing positive. So it's important to interpret these geographic data with both of these maps in mind because they give slightly different information. But we are seeing that in certain parts of the city, the percent positivity rate is very high. So I'm going to focus now on describing some of the clinical features of COVID-19 based on data from a variety of different jurisdictions and parts of the world. The incubation period seems to be a mean of approximately 5.2 days with a range of 2 to 14 days. As a reminder, the incubation period means the time between exposure to the onset of symptoms. The median patient age reported in China is 49 to 56 years of age, and transmission is primarily driven through respiratory droplets. Some extent to some extent, there is transmission through the direct or indirect contact route. We are increasingly recognizing the role of pre-symptomatic and asymptomatic transmission. So by pre-symptomatic, that means that people who are capable of transmitting the infection to other people before these individuals who are infected have any signs or symptoms of disease. And asymptomatic transmission refers to people who never show any symptoms or signs of disease, but have transmitted the disease to others. There really is not any strong evidence of airborne transmission to date. And the virus has been detected in feces, which raises the possibility of fecal-oral transmission. The symptoms tend to be very nonspecific, including fever, dry cough. Less frequently, there can be myalgias, headache, sore throat, diarrhea. And anecdotally, we are hearing about loss of sense of smell and also loss of taste. Okay, sorry, continuing on. The next slide further describes some of the clinical features. There seems to be, at least in people with more severe illness, a prominent component of lymphopenia, a prolonged prothrombin time, elevated lactate dehydrogenase, and radiographically in people with more severe illness, chest x-ray can show bilateral patchy infiltrates, and chest CT can show ground glass infiltrates. This slide shows some data based on a US study, or this slide shows data from the United States from around mid-February through mid-March, including approximately 4,200 people. The case fatality rate observed in this case series is approximately 1.8 to 3.4%, and it varies depending on the age group. So those of older age have a higher case fatality rate. And severe disease, however, is not uncommon in younger people, because in looking at 508 hospitalized patients, approximately 40% were aged less than 55, and of people admitted to the ICU, nearly half were less than 65 years of age. There's a variety of factors that we are aware of for severe COVID, and those include age greater than or equal to 50 years, people with chronic medical conditions, including chronic lung disease, heart disease, diabetes, cancer, or a weakened immune system. And there are other medical conditions that also can increase risk, including blood disorders, chronic kidney disease, chronic liver disease, possibly current or recent pregnancy, and neurologic or neurodevelopment conditions. Therapies for this illness are currently supportive. So there's no drugs approved by the FDA, the Food and Drug Administration, treatment of COVID-19. Several drugs are being explored right now, including hydroxychloroquine and chloroquine, as well as remdesivir. But there are no reliable data right now that strongly suggests that they need to be used. And we're going to dive into that in a little bit more detail in a moment. As well, there was some concerns about use of certain NSAIDs, but there's no strong data that supports the claim that NSAIDs can contribute to poorer outcomes. And by NSAIDs, I mean non-steroidal anti-inflammatory drugs. And bottom line, though, is that a variety of different treatments and vaccines are currently under development. And there are some different resources you can look at to get information on them, including at the Milken Institute. So when it comes to critically ill adults, there are multinational guidelines available that include recommendations on infection control, resuscitation, ventilation, and therapy. In terms of therapy for critically ill adults, unless people have acute respiratory distress syndrome, steroids do not seem to be indicated. Empiric antibiotics might be of use in ventilated patients. There is potentially a role for convalescent plasma that's undergoing investigation, as well as other biologics, such as monoclonal antibodies, that's also under investigation. Right now, though, it's not recommended that IVIG be used, convalescent plasma, lopinavir, ritonavir, unless it's part of a study setting. And there's also insufficient evidence on the role of antivirals, chloroquine, and other medications and drugs in the setting of COVID. So if you want more information, you can also check the University of Nebraska that has information on dosing for some of these medications. Again, consider using them as part of a study, and be mindful that these are not fully evaluated at this time for COVID. It's important also to keep in mind the risk of treatment shortages. We recommend avoiding prescribing medications that are under investigation for the treatment of COVID-19 to patients with mild or moderate illness. And the reason for this is that we want to prevent shortages for other approved indications for these medications, and also preserve supplies for hospitalized patients with COVID-19 so that these more sick individuals with COVID can get the medication if they need it. And also be aware that New York State Executive Order 202.10 says that no pharmacist shall dispense hydroxychloroquine or chloroquine except when prescribed for an FDA-approved indication or as part of a state-approved clinical trial related to COVID-19. Vaccines, unfortunately, are not yet available. That is going to be a game changer when they do become available. There are vaccines, fortunately, under development, including in phase 1 trials, but just be aware that it'll be at least a year to a year and a half before a vaccine becomes widely available. I'm going to shift gears now and talk a little bit more about the healthcare system side of COVID-19. The New York, so there is a hospital evacuation coordination center, and the New York State Health Department is leading that HEC. And the purpose of the HEC is to coordinate patient movement and patient tracking between hospitals and alternate care sites. New York City Hospital should have received a notice from the New York State Health Department describing the transfer and patient tracking process on March 31st. And again, just to be clear that this talk right now is being given to you by a New York City Health Department employee, and the New York State Health Department is an independent agency. Also, the Greater New York Hospital Association held a webinar for hospital leadership to discuss this process for evacuation coordination on April 1st. Bottom line is that transport arranged through the National Ambulance Contract must be requested through the HEC process, and patient movement is tracked by New York State Health Department through the e-fines system. So if you have questions about e-fines or the HEC, talk to your hospital administration. As you might be aware, there are concerns that current bed capacity in established hospitals across New York City will not be sufficient. I told you before that things are going to get worse before they get better, and we are expecting to see the case count rise each day in the coming weeks. That also means that the number of people who die will also unfortunately be increasing in the coming weeks on a daily basis. And so alternate care sites have been set up to help relieve some of the burden on hospitals. And those alternate care sites include the Javits New York Medical Station, so that's at the Javits Center, and they are currently accepting low acuity non-COVID patients who could be discharged to a community setting with home care but need additional assistance with management of chronic or acute medical conditions or activities of daily living. They are working right now to increase capability at the Javits Center to accept higher acuity patients. And note that the admission criteria for the Javits New York Medical Station might change in the weeks to come. There is also the U.S. Navy ship Comfort, USNS Comfort, that is docked in the New York City area, and they are currently accepting medical surgical level patients. These patients must be negative for COVID-19 before they are admitted to the ship. And there are other alternate care sites in development. We're now going to talk a little bit about overall strategy from a public health perspective. You've probably heard the term flatten the curve, hashtag flatten the curve. And this is a key component of what we are doing right now. It is critical that we slow the spread of COVID-19 because by doing so, we are going to prevent a surge of cases into the healthcare system. And that's demonstrated in this figure. The x-axis shows the number of days since the first case. The y-axis shows the daily number of cases. So focus first on the solid purple area. This curve in solid purple shows a pandemic in the setting of no intervention. You see that the daily number of cases surges very quickly and gets high very, very quickly. And so what we mean by when we say flatten the curve is that we want to push that curve down. Maybe the total area of under the curve will remain the same if we flatten the curve, but the curve will be spread out, meaning that the daily number of new cases will decrease and will push that peak of that curve to a later point in time, allowing us more time to prepare our healthcare system for this surge in cases and better develop infrastructure. All right? So flattening the curve is critical from a public health perspective. So how do we flatten the curve? That's shown in this figure right here. This figure emphasizes that we have to have an adaptive response to a pandemic. If you look at the very top, you see waves, right? So those are the cases over time. That's similar to the prior figure we were just looking at, which is basically an epidemiologic curve. And now I want you to take your eyes and look at the very bottom of the slide, which is that ribbon in red that says containment, mitigation, suppression, and prevention. Those are the various different types of responses that we can have. So early on in the outbreak, you want to use a containment strategy. Maybe the containment strategy is very effective and you can end the outbreak at that time. But sometimes the outbreak just keeps pushing forward to a point at which you have to abandon a containment strategy and move to a mitigation strategy. And the mitigation strategy applies when you have that huge surge in cases. And again, this is where we are trying to flatten the curve. We are mitigating the impact of this pandemic by flattening the curve. And once we flatten the curve enough, we will eventually move into a suppression phase. And when we get out far enough, we can move into a prevention phase. And that's when we have the vaccine. So I strongly recommend that you take some time to look at this slide when you have a moment to understand what are the public health strategies behind controlling this outbreak, this pandemic. And right now, we are currently in the mitigation phase. So we're not doing extensive contact tracing right now. That is not the goal. Doing extensive testing is not the goal right now. The goal is on non-pharmaceutical interventions and protecting our healthcare system, protecting all of you on the front lines. That is what's most important right now, in addition to supporting society. And so when we talk about protecting the healthcare system, that means giving you all infection prevention and control guidance and personal protective equipment, and making sure that appropriate clinical care can be delivered. When we talk about non-pharmaceutical interventions, well, that means that we have community engagement, that we continue to engage non-pharmaceutical interventions, NPIs, that we always should be doing, washing our hands, covering our coughs, staying home when we're ill, but we have to have a heightened adherence to these non-pharmaceutical interventions. We have to continue doing environmental non-pharmaceutical interventions. We have to do personal non-pharmaceutical interventions that are unique to a mitigation, to a pandemic. And that is where staying at home, household quarantine is so important. All right? That is why we are doing social distancing, closing schools, because that is the best tool we have right now in the absence of a vaccine. So we're going to talk now about the prevention measures. All New Yorkers, including and especially healthcare workers, must act as if they have been potentially exposed to COVID-19. We are in a pandemic. All of us have to act as if we have been exposed. And that means that all of us need to be self-monitoring every day for COVID-19-like illness. And everyone needs to be social distancing. Some people are not fans of that term, social distancing. They prefer physical distancing with social connectivity, whatever way you want to call it. But that means that you need to be staying at home to the extent possible and only leaving for essential tasks. And you should keep a minimum of 6 feet from others whenever possible. You need to be continuing individual measures, hand hygiene, cover your cough, staying at home if you are sick. And again, remember the difference between the term isolation and quarantine. They're not interchangeable terms. Quarantine refers to the separation of well people who are exposed to the virus, so meaning that those individuals have no symptoms, but we're separating them. Isolation refers to the separation of sick individuals who have been exposed to the virus. So they're two different terms. Do not use them interchangeably. So self-isolation means that anyone with possible or confirmed COVID-19 needs to self-isolate until all of the following are true. It has been at least 7 days since the person's symptoms have started. The person never had fever, or the person has not had a fever for the prior 3 days without the use of fever-reducing drugs such as acetaminophen or ibuprofen. And the person's overall illness has improved. All of those criteria must be satisfied for a person with possible or confirmed COVID-19 to be released from self-isolation. Not everyone needs to be tested. We talked about this a moment ago in the mitigation phase. Testing everyone is not an effective strategy at this point in the pandemic. Testing is not indicated for people who are not hospitalized. Only test people who are hospitalized. Ask most of your patients with mild or moderate symptoms compatible with COVID-19 to stay home for them to recover. They should be self-isolating. We discussed on the prior slide how long they should be self-isolating for. And you can tell people asking for testing why they should not get tested, and that includes testing requires medical equipment and other resources that are in short supply that should be reserved for people with severe illness. That when a person with mild or moderate illness travels to get tested, they can be exposing other people. Let's say the individual is not infected, but they're traveling to go get tested. They might get infected in the process of traveling. Getting that test result will not change what is done for the individual. And there's a risk of false negatives. So it would be sending the wrong message if they get a false negative result when in fact they are positive. So please go to our website for more information. You can always consult us at our provider access line. That's 24/7. We send out health alert notices and dear provider letters, and we do webinars such as this. So we've released a number of health advisory notices in the last several weeks. Number 6 focused on adoption of droplet PPE, testing criteria, and home monitoring and self-isolation. Number 7 focused on healthcare worker self-monitoring and work restriction. Number 8 focused on unnecessary testing and the need to conserve PPE and preventing exposures. And number 9, which was just released yesterday, reminds providers to preserve personal protective equipment and informs you all of the facility types that are prioritized by the health department for PPE distribution. So all of you need to be maintaining awareness in your facilities for COVID, updating staff regularly on the outbreak, disseminating information from the health department, advising people with mild or moderate illness consistent with COVID-19 to stay home, and they should only go to the ER for severe illness, implement policies and procedures to minimize exposures to all respiratory pathogens, and in particular SARS-CoV-2, having a continuum of infection control measures throughout the patient's visit until after the patient has left, and protecting those at increased risk for adverse outcomes from COVID-19. So the pillars for all of you are triage, isolate, and inform. Triage meaning that if patients really need care, advise them to call ahead. You should post signs around your healthcare facility and greeters at points of entry so that persons with COVID-19 like illness can quickly be identified. Separate those individuals with COVID-19 like illness from others while they are waiting. Triage personnel should be handing out face masks and tissue to people with COVID-19 like illness and put a face mask on those symptomatic individuals. Then these symptomatic individuals need to be isolated in a private exam room. An airborne isolation room or a negative pressure room is not required unless the patient is undergoing an aerosol generating procedure. And note that collecting an NP or an OP swab is not an aerosol generating procedure. If a private exam room is not available, identify a space where the patient can be separated from others by more than 6 feet with easy access to respiratory hygiene supplies. And in some cases, you might be able to have the patient wait outside in a personal vehicle or just wait outside the facility. Patient rooms do not need to be left empty after the patient leaves unless aerosol generating procedures are performed. And then in terms of informing, we have automatic ways that every time a patient is tested, and not every patient needs to be tested, only if they're inpatients, but if a patient is tested and is positive, we automatically get those results. So we're automatically notified. For personal protective equipment, protecting you all is a top priority. And I said it again at the beginning, and I'll say it again now. We are so appreciative of all of the sacrifices that you all are giving and your service, because we know that it's hard. There's a lot of pressure. You're being asked to do things that you've never been asked to do before. You're working outside of your comfort zone. It is hard. It is scary, and we really appreciate what you're doing. And you are providing an essential service for New Yorkers. And I hope you feel recognized for the sacrifices you are making. Per CDC guidelines, most patients can be managed with droplet precautions. And that means using the following PPE with the addition of eye protection. So that's a face mask, a gown, and gloves for contact precautions, and eye protection. An N95 or a PAPR is not needed for routine non-aerosol generating care, but is needed, either one of those, for aerosol generating procedures or for caring for critically ill patients. Sadly, we are in a place where there are shortages of personal protective equipment, and that just adds to the anxiety of the scenario. Facilities must conserve N95s and other PPE. Generally, we prefer extended use of PPE, or we recommend extended use rather than reuse. And the reason for that is because there's a lower risk of self-contamination from the donning and doffing if you do extended use rather than reuse. Reuse means that you're using the same PPE for multiple encounters with patients, but you're removing that PPE between each patient encounter. So if you're going to be reusing, make sure that equipment is safely stored between patient encounters. And you should never take that PPE outside of patient care areas unless it's been decontaminated or placed in a breathable container. For more details on this, please see our latest guidance on this that we released several days ago. So in terms of testing, there are different ways you can get that molecular PCR test performed. Be careful with serologic tests right now. Go to our website, the provider page, for some more information on the serologic test. Right now, though, if you want to test your patient for coronavirus, you have to use a molecular assay. That can be done at commercial labs, hospital-based labs, or at the New York City Health Department Public Health Laboratory. Only test hospitalized patients. And assume that any patient with new fever, cough, shortness of breath, or sore throat has COVID-19. Just assume that. We have so much COVID-19 right now, you don't need to test them if they're not hospitalized. To test, again, you can refer to your commercial lab or hospital-based lab, or you can go to us if the patient is hospitalized. If you're going to go through us, that requires pre-approval, and that is done by calling the number listed there. And you also have to have an e-order account. And so go to the website listed here to get instructions on how to sign up for e-order. So when you're ordering from us, if we approve the testing, the next step as a clinician, you need to send those specimens to your hospital central lab. And we're going to give you an assigned unique identification number over the phone when you call us for that pre-approval. So send that number along with your specimens to your hospital central lab. And then your hospital central lab will submit the requisition in e-order. And then your hospital central lab needs to call us back, and we can arrange transportation to get the specimens from the hospital central lab to our lab in downtown Manhattan. You all, as ordering providers, are responsible for giving patients back the results, not the health department. And you collect one NP and OP swab when you're testing patients, package them in the same viral transport media collection tube. You can also submit a lower respiratory tract specimen. When discharging patients, you do not need to get a negative COVID-19 test result to release a patient from a healthcare facility. In terms of monitoring for all of you as healthcare workers, you are at risk for unrecognized exposures. First of all, through the work that you're doing, but also every time you leave your home. Coronavirus is everywhere right now. So we all need to be monitoring ourselves for illness consistent with COVID-19. And that means as healthcare workers, you need to take your temperature twice a day and evaluate for a new onset of any of the following symptoms, such as a temperature greater than 100.0 or 37.8 Celsius, or subjective fever, cough, shortness of breath, sore throat, and also look out for other less common symptoms. Have a low threshold to talk to your occupational health department. If you develop a mild or moderate illness, stay home and self-isolate until all of the following are true. That it's been at least 7 days since your symptoms started, that you've not had fever during the illness, or that you've not had fever for the prior 3 days without the use of fever-reducing drugs, and that your overall illness has improved. Employers may require that you active monitor yourself and report your symptoms. Your employers might have additional guidance for you. So we do not, as the health department, require healthcare workers to undergo quarantine or a negative test result before going back to work if you all have been exposed. But you all should talk to your employer if you have any questions about returning to work after completing isolation. And don't forget, if that you are an Article 28 facility, you have to follow the guidance of the New York State Health Department. I am part of the New York City Health Department. I'm not part of the New York State Health Department. These are two different agencies. Often we are confused, but we are different. Sadly, in the setting of this pandemic, we need to anticipate supply shortages, including of PPE, which we talked about. And because there are shortages of PPE,
Just tell them it's
one moment.
audio that it said connectivity.
Because there are shortages of PPE, we are using existing stockpiles to share PPE. And those stockpiles are coming from the local, state, and federal levels. New York City Health Department has been distributing PPE to hospitals, nursing homes, visiting nurses, caring for patients with COVID, EMS, meaning emergency medical services, dialysis centers, and group homes that are licensed under certain circumstances. Okay, so just be mindful that obviously PPE is in short supply, but also other medications and medical supplies might go in short supply. Hospital beds, you all as healthcare personnel, ventilators. And the reason I'm saying you all as healthcare personnel, because sadly, some of you are getting COVID-19, and that puts you out of work. And unfortunately, some of you are going on to develop severe illness. So I understand how scary it is and challenging it is being on the front lines like all of you are. All of these circumstances mean that we need to start planning together for contingency and crisis standards of care in the setting of limited resources. This is a real sad reality of where we are right now in the setting of this pandemic. And like I said before, it's going to get worse before it gets better in New York City, but it is going to get better eventually. We will work together. There is going to be an end. We don't know when that is, but there will be an end. Environmental cleaning. Rooms need to be cleaned and disinfected before returning to routine use, using EPA-registered hospital-grade disinfectants. Make sure that they're being used in accordance with the manufacturer's instructions. Contaminated waste can be treated as routine medical waste, and just make sure that standard operating procedures are followed when processing linens. So in terms of steps to take now, the priority is preventing nosocomial outbreaks, meaning keeping all of you safe and your patients safe. Review our guidance, please. Review other guidance from CDC and the New York State Health Department. We are all in this together. Train your staff, train yourselves, educate others. Make sure you're getting information from reliable sources. There's a lot of misinformation out there. Be aware of how much PPE is in stock and environmental supplies. And distribute information also to patients, staff, and families and visitors. You all need to be planning for a surge in patients, potentially, or how to do healthcare worker self-monitoring. Staff need to stay home if sick, hopefully be incentivized to stay home if sick. Visitor management is very important. Staff shortages, there have to be plans for how to address that. Looking up altered crisis standards of care, and also being aware of environmental protocols. Along these lines, implementing triage protocols, canceling elective admissions and procedures, and implementing telemedicine services. So for more information on crisis standards of care, please see these websites. And here's more information. Again, you can always call the New York City Health Department if you have any questions. There's also the New York State Health Department if you're not based in New York City. And with that, just want to let you know that there's going to be upcoming webinars. We're going to be changing the days to Fridays going forward. And I just have to end again by thanking you all for all of your service. I trained myself in New York City. I have friends on the front line. And I'm hearing stories from them. I know how hard it is, and we are so appreciative of the work you're doing for your patients, for your family, for all of New York City. We're benefiting thanks to your sacrifices.
Great. Thank you, Dr. Vora. So just a friendly reminder that if you do have questions, please submit them into the chat box and we will do our best to address them. I think we have a few that we can get started with right now. One question that we've been getting several variations of is whether or not patients should be tested in the outpatient setting, and why or why not.
So I'm going to quickly go back to a slide that we talked about before. 2 slides, in fact. I hope you all can see this. Let's start with this slide. Because the question was about, should patients be tested in the outpatient setting? We are right now in the mitigation phase of this pandemic. And that means that extensive testing at this time is not the best use of resources. Not because first of all, we understand that patients want to know, but given that there's so much COVID out there, if someone has a COVID-like illness, assume that they have COVID and they should just be taking steps to isolate themselves at home. They do not need to be tested. And let's dive a little bit deeper into why they might not need to get tested. And that's explained on this slide right here, which is why should we not test outpatients? First of all, testing outpatients is using up scarce supplies of medical equipment and other resources that should be reserved for those with most severe illness. We are using up PPE, personal protective equipment, testing outpatients when we need to be reserving that PPE for the inpatient setting. Another reason why patients should not be tested in the outpatient setting is because if they have COVID, in the process of traveling to that medical clinic, they might be exposing others. Let's say that they do not have COVID-19, but they go out to get tested. In the process of traveling to that clinic, they might get exposed and infected. For most people, getting the result as an outpatient will not change management. And finally, there's a risk of false negatives. And so it provides false reassurance. So they might get a false negative result when in fact they have the illness. There is going to be a point, let me just say one last thing. There will be a point in time in the future when it'll be important again to start doing extensive testing, but that time is not right now.
Thank you. Another question we have is there any guidance on how long COVID-19 can remain on non-porous surfaces?
There is some information out there that potentially the virus can remain on surfaces for an extended period of time. But again, some of these studies are done in a laboratory setting, which is not real life. And so there's a lot of different factors that go into the possibility of the virus's viability on an environmental surface. And this underscores why it's important to be taking routine measures at the personal level for everyone. We always need to be doing this, but especially in the setting of this outbreak, which is washing our hands with soap and water or an alcohol-based gel. Do not touch your face, especially your eyes, nose, and mouth, with unwashed hands. Cover your cough so that you're not spraying droplets all over the variety of different surfaces. And so these are just basic steps that we all have to be taking. And we're increasing. The reality is, though, that you're not going to be able to know on every surface if there's a virus, and that is why you have to take these precautions to keep yourself and others safe.
Thank you. There are also several questions about how long patients might be contagious. So we have here, would a person with a cough or rhinorrhea, even improving, be allowed to return to work if they don't have a fever?
For this, I'm going to see if I can find the slide very quickly.
And similarly, if the person's only symptom is a loss of smell and taste, are they considered contagious?
So I'm going to first describe the common symptoms that we're very well aware of are fever, cough, shortness of breath, and sore throat. So anyone with those symptoms should be assumed to have COVID-19, even if they do not have a test result. And if that person is a healthcare worker, if they're not that sick, we also have the same recommendation that they should stay home. And the duration of time that any individual should stay home, including healthcare workers, is that it's been at least 7 days since symptoms have started. So all of the following must be true, right? That I'm about to say. And look at this slide at the top of the slide, right? All of the following must be true. It's been at least 7 days since symptoms started. The person never had fever, or they have not had a fever for the prior 3 days without the use of fever-reducing drugs, and their overall illness has improved. It might take weeks for the cough to completely resolve itself. We've seen that with other upper respiratory illnesses as well. So again, this guidance though is going to be sufficient for the vast majority of people. And the other question about other symptoms, we're increasingly recognizing that there are other symptoms beyond the fever, cough, shortness of breath, or sore throat that might present in a person with COVID. Possibly loss of smell, loss of taste. Ongoing investigation is needed. So you all, as clinicians, can make that determination whether you think that a person coming in with loss of smell might have COVID-19. Keep in mind that everyone in New York City at this point is considered exposed to coronavirus. They don't have to report a known exposure to a confirmed case, or they don't have to report recent travel from a COVID-affected area. Every New Yorker is considered exposed. As soon as you have symptoms consistent with COVID, assume that you have COVID.
Great. We're also getting questions about GI illness. Have we seen any increase in patients with GI illness who are confirmed COVID positive?
There are reports of diarrhea in patients with COVID, not as prominent of a presentation symptom as others, such as cough. It's also been identified, the SARS-CoV-2 has also been found in feces. So there is the possibility of potentially a fecal oral transmission. In terms of tracking syndromically whether GI illness has increased across New York City in emergency departments, I'm not aware of that evaluation, and that's something that I'll have to look into.
There are also several questions about reinfection and whether or not there's any data that supports whether or not a patient can get reinfected with COVID once confirmed.
The reality is that emerging infectious diseases are on the rise around the world, and these are largely driven by environmental changes. And that means that we're going to be coming across new viruses, such as this one, or there's going to be the reemergence of viruses that we previously might have discovered in the case of Zika back in the 1940s, but then in the setting of the modern world, we can find explosive outbreaks. And what we sadly are realizing is when these outbreaks of emerging infectious diseases occur, we learn a lot about these viruses in the setting of the outbreak. So the question was about reinfections. This is unfortunately something that we don't have enough information on to say definitively or not whether reinfections can occur. And we're going to have to learn this over time. The situation is evolving. We need to update our recommendations based on the latest science. And so we're giving you guidance based on the best available information that we have. And that might change tomorrow or next week as new information emerges. So whether a person who's been previously infected can get reinfected, we don't know. We just like many other viruses of a similar nature, we believe that there's at least temporary immunity, but how long that immunity would last is not really clear, and that's something that we're going to have to learn. And that's why, ongoing infection prevention measures are really important. That even if you are a healthcare worker who previously had COVID and now you're back in the workplace seeing patients, it's still important that you keep using that personal protective equipment.
We have a few logistical questions here. One being patients who are vulnerable and possibly quarantined at home that have symptoms consistent with COVID-19. How do they get care if transportation is a problem?
This is a real challenge, especially in a city like this where probably most people do not have their own car. And it's really important that we recognize that infected individuals should stay home for a certain duration of time that we've talked about already on this call. Hopefully, these people have a social support system if they are still within that period of time. So hopefully they have a social support system through which they can leave. They have a social support system that can help them get necessary supplies like groceries or medications from the pharmacy. But that's not going to be the case for everyone. And so that means that in some cases, sick individuals might have to leave their home, even within that 7 days of the onset of illness. If you have ill individuals, if you have patients who have to leave their home, please advise them to cover their nose and their mouths so that they have some type of source control. Remember, masks are used for two reasons. Reason number one is for personal protection, which is the case for a lot of you all as healthcare workers. You're wearing masks when seeing patients for personal protection. But the other reason that masks are used is for source control. So that if an ill individual has infectious droplets, wearing that mask provides some type of source control and prevents the transmission of those droplets to others, the dissemination of those droplets to others. And so, again, in the case of a sick individual that needs to leave their home before 7 days have passed, please advise them to wear a mask to cover their nose and their mouth. So that will provide some type of source control.
Okay, and then one last question. There have been comments from staff that they're experiencing shortages of their critical care nurses and advanced care professionals. Are there any plans to bring resources into the region?
The capacity of our healthcare system is of utmost concern. I've said it before, and I'm going to say it again, that things are going to get worse before they get better. I know you all are already working at 100%, if not beyond that, and that's going to be necessary for the weeks to come, unfortunately, and the months to come. In terms of extra resources, we talked a little bit about alternate care sites, and so there are some settings such as the Javits Center for lower acuity patients, and also the U.S. Navy ship, the Comfort, which also can take some patients as well, but those have to be COVID negative patients. This is an ongoing area of discussion to make sure that we continue to bring in that bed capacity, the ventilator capacity for New York City. And we're working at multiple different levels of government and with healthcare system, both the public and the private healthcare system, and with other organizations so that we can enhance our ability to support the healthcare system and bring in those beds and ventilators. And so, again, this is just an active area that there's a recognized need and there's ongoing efforts along those lines. And so I believe that was the last question. Now, before I turn it back over to Kathleen, I just want to say thank you all again for all of the work that you're doing on the front lines. I hope we can continue to have this conversation. Make sure you're getting information from reliable sources. We hope that you keep coming to us for your information. And you all, again, are our heroes because you're on the front lines, putting yourselves in harm's way sometimes and really providing amazing care for New Yorkers. So thank you.
Well, I don't think I could close it better than that, but I just want to say that these slides and the recording will both be available on our website, so you should be able to download the slides, the PDF, and we'll also have the audio recording of this website. We understand that as time advances, you're going to have more and more questions, and we want to be here to answer them for you. We are having these calls on a regular basis. The next 3 will be on Fridays at 2 p.m., so that